Good afternoon. Hi, I'm Bill Coase with the Blanchard Valley Health System. We're here today. We're going to be talking about navigating. You may remember a month or so ago we had Dr. Eric Browning and Adele Simon here to talk about our breast care, or what's good care when someone has breast disease of all kinds. And today we're going to talk about the navigation system specifically related to when someone has breast cancer. Before we start, reminder, if you have any questions, fill out the chat, send those in. We'll try to answer as many of those as we can. Also, we have a survey at the end, and we'd appreciate your feedback as to things that we might want to talk about here on these kinds of sessions. And in addition to that, any other kind of feedback about thoughts, let us know, and like I said, we will try to get back with you. So I have two guests here with me today. Both work in our Arms Family Cancer Center. And Sarah, why don't you introduce yourself? Tell us a little bit about your background, how you got into this, and then we'll make sure both of you get a chance to say something. And then we'll just talk about navigation.
Hello, my name is Sarah Summit. I'm an oncology navigator at the Arms Family Cancer Care Center. I've been there for about 8 years now. My background actually started out as a labor and delivery nurse, and it was a personal experience that led me into navigation. I then moved on to Avita Health System on a grant-funded position and started their navigation program there. I wanted to get closer to home, which led me to Blanchard Valley Health System, and I've been in this position for 8 years.
Great.
Yeah. My name's Jessica Gordon. I'm a registered nurse. I started out with Blanchard Valley about 9 years ago as a pediatric medical assistant. I decided to go back to nursing school. Once I decided to go to school to be an RN, I went ahead and got a job at the Arms Family Cancer Care Center checking in patients. I fell in love with the dynamics there, the patients, and how well the center worked. So then I went on, I graduated and became ultimately a navigator with Sarah.
So Jessica, what's a navigator do? Okay, so we're talking about navigation. I think we all have a definition. What do you do in your job capacity?
Sure. So when we first meet with patients, there's a lot of learning from patients as to what all things do we need to help them with. So a lot of people don't even know what navigation is. A lot of what we do is educating, supporting them emotionally, mentally, securing them with resources. It could be community resources, it could be national resources, it could be resources within our system or even at the cancer center. So it's a lot to do with eliminating those barriers that they may have to the care that they need to receive.
And would you add anything to that? I mean, how do you see your position as to what your job function is?
Our goal is to always make sure that patients are comfortable with their care, that they have a good understanding of what the next steps are. So we do a lot of education on that. We do a lot of coordination of care between physician offices, and we want to make sure that all of those questions are answered and that those patients feel comfortable with moving on to that next step in treatment.
So let's just I think for anyone that's listening, whether you're male or female, and I think we talked about that last time, 1% of breast cancer can be male, so this is not just female. It's got to be a little bit emotional to hear that. And when would you, let's just say we'll track a patient, when might you get involved? I mean, the first thing could be somebody just says to you, your mammogram looks abnormal, and we need to bring you back in and have a diagnostic test or things like that. When do you get involved, and how do you get involved? Do I make the phone call to say we need a navigator, or are you working with the team out there that you get in touch with someone right away?
Yeah, we have an exceptional team of people. So all of our breast imaging is performed at Eastern Woods Outpatient Center. There are nurses at Eastern Woods Outpatient Center that we work very closely with. So they perform like all the calls for like callback for additional views or biopsy. If we need to get involved with a patient prior to when our first step would be, they would reach out to us. But for any patient that is set up for a breast biopsy at Eastern Woods Outpatient Center, they are then scheduled for a results consult to go over those results with the radiologist. It's that point that we're present. So we are there the day that that news is being delivered to the patient. The radiologist will go over the results with the patient and talk about what the next steps need to be for them. They are then handed off to one of the navigators at the cancer center, at which point it looks a little bit different for each patient, but typically we would provide additional education on their pathology report. We would talk about what the next steps are going to look like for them as far as getting them into specialists. Sometimes I think it gets a little bit confusing to patients why they're seeing so many specialists for one diagnosis. So it's a lot of education on what that care team looks like and why. At that point, if the patient is ready to make decisions on providers, then we will make those appointments so that they leave that day with them. But other patients, they want to go talk to family, friends, to their primary care physician to get input and recommendations. So we basically become the point of contact for that patient the day that they receive their news. And moving forward, we have numerous contacts with them, which look a little bit different for each patient.
So Jessica, you would be in the room if, let's say, I'm the radiologist and I would be talking to Sarah, and you would be listening, and then after, let's say, whatever information that I give as the radiologist or what, then you would sit and talk to someone and kind of go through that, see what questions, and that starts really early on then.
Correct. Yes. I think one thing that really drew me to this profession is that close bond, and it starts right then and there. You can only imagine what you feel that moment you get that news, but to know that someone is there that understands what's going on and can direct you in the right way, I think helps patients, not with receiving the news, but at least moving forward and knowing that they can contact someone with any thought or question that they may have moving forward. I think we use the time, and this could be, depending on how much information we need to go over, it could be a couple hours of a visit that we sit with the patient and make sure that they understand everything that is going to happen within the next week to a couple of weeks in that first treatment. So we use that time to really tailor our plan to what their needs may be in the future.
Yeah, maybe just making a comment that going back to our discussion before, when I started practice, which was a long time before both of you were born, there wasn't a lot of treatment for breast cancer. It was basically a mastectomy or a radical mastectomy. And without going into all of that, I think you both made a really good point. There are so many different ways this can be treated now, depending on the staging and some of the things that we talked about before, that it does become not only complex, it can get a little chaotic trying to keep track of that. And imagine, and again, I mean, let's just take any kind of example you want for any female or male, but for any female, especially if you're younger, I mean, you're sitting there, what's going to happen to my family? What's going to happen to me? All of this that, gee, I just thought I had this lump in my breast and this is not looking so good. I'm going to be dead in 6 months, and who am I going to tell? I mean, you can, I'm sure you're hearing all of those kind of things. So part of it is the initial conversation, but then there's a lot of follow-up. I mean, in this day and age of artificial intelligence and Google, and I'm sure everybody has all kinds of opinions. So you keep in contact with them then. And how do you go about doing that?
That looks differently for each patient. I would say we are contact with the patients from the time that they leave, the day that they hear the news that they have cancer, to the time that they get into their first provider is numerous contacts. Oftentimes patients tell me that it's a roller coaster of emotions, and we are that contact for them for the many questions they have, which often we end up developing a list of questions for the specialist that they're going to go to and help them prepare for those appointments. But it definitely looks different, and it's very individualized for each patient, the amount of contacts that we need to to have with them. And that can be a phone call, that can be meeting with them in person. It really is just individualized to their needs and what they want.
So the coordination of those things, we have a tumor board, and we talked about that before, where the medical oncologist, the radiation oncologist, the surgeon, the pathologist all sit in, really come up with a treatment plan. How do you get involved into that? I mean, about, well, somebody's going, gee, I don't even know what radiation is. That's really dangerous, isn't it? They're not going to ask the doctor that. I mean,
No.
I understand that you're going to be the person that they ask, that they develop that relationship and have trust. So how do you coordinate all of those things with all these different people that could be part of the situation?
It's a lot of education on each specialty and how they will impact the patient's care. A lot of times we'll have a conversation with the patient prior to each consult with each specialist to make sure they have a good understanding of like what to expect, what questions to ask. And then we do a follow-up phone call after those consultations. Oftentimes patients say that they like heard one thing during their appointment, or they dwelled on something. So we will review the information that was presented to them at their consultation and make sure that they feel comfortable with what the next step is.
So that's a great point, and I get a lot of people will ask me, I'm going to go see somebody, what should I expect? Well, here's also some questions. So how do you go about that, Jessica? I mean, okay, I'm going to go see the radiation oncologist. I'll use them as an example. Here's some things you want to listen for, or here's things, maybe what kind of advice do you give them, kind of questions to ask?
So in our first meeting, we do use an educational book. And in that book, there is different questions that I say we will open these up at a different time and we'll go over these before your consultations. I actually use that material over and over again throughout the patient's course of treatment. And a lot of times what I tell them is, these questions might spark another question that's personal to you. You know, that maybe, the person before that consulted may not have asked. So a lot of time it's just learning their family history, their personal history, and that can sometimes cue questions that will be personalized for them at their consultations. And that's usually how we can go about getting those unique questions to the providers.
And I assume that if there is a question, that then you could be in contact with that group of physicians, I said, to get clarification that you could get back.
Absolutely. What's very nice about Blanchard Valley Health System is that I know for sure that those providers talk amongst themselves about each patient and their plan of care. And because of that, I'm able to ask those more personal questions that maybe the patient didn't even think of in their meeting. And they're able to discuss it amongst themselves and able to give me an answer for that patient, which is very nice.
Okay. Jen, have we had any questions come in so far?
We have. We've had a few questions come in today. The first question is, can anyone in the community with cancer utilize the care navigators at the ARMS Family Cancer Care Center?
So the question was, just in general, at a high level, are the navigators available for any kind of cancer? I think that would be the intent of the question.
Absolutely. We want to be available to the community for any needs, for any access to care that they may receive. I think it's important to point out that we also have care navigators, not just in oncology. There's care navigators that are at the primary care offices, in the emergency department, the pulmonary office. So having that collaboration is also great. So I would encourage anybody that is having like any barriers or issues with access to care to get connected.
Yeah, I'll just make an editorial comment. That's a great point. From a community health needs, one of the things we're working on with public health, in addition to a lot of the nonprofits, is this idea of navigation. And a lot of it is because of complexity of what's occurring, in addition to being able to get to resources and all of the things that are needed. So that's a really good question, a really great answer. Jen?
Is there someone at the ARMS Family Cancer Care Center who can assist patients with financial decisions?
So let's talk about that. Just a couple of the things I want to make sure we cover. One's financial and the other's emotional support. I mean, that can be. So the question was asked about financial. How do we go about trying to help them with all the deductibles and pre-authorizations and things like that? How do you two do that, or is that part of working with another member of the team?
We do. We do have more than just me and Sarah part of our team at the Arms Cancer Center. We do have a financial navigator. We also have clinical research there. We have an oncology registered dietitian as well, amongst other services. So if we know that a patient is having financial hardships, or say they might have a lack of insurance or no insurance at all, we connect them to that person, and she does a complete review of their finances and tries to find them whatever assistance out there. And that could be community resources, that could be a national resources, and also if they need medication, things like that. She also works with drug programs and manufacturers as well.
So let's just talk about that a little bit, because I think I would be concerned about that just when you read about some of these drugs that are $150,000 a year. How am I going to pay for those kind of things? How do we go about that general evaluation? Because I'd like to say, I think we make as much of an attempt as everyone does in healthcare to get to the best plan and to find those medications. Now, sometimes we don't always have them available with what we've had in shortages, but there's lots of different ways that's looked at. How do we go? You have any other thoughts about that, Sarah?
We just in general in navigation, between Jess and I, financial navigation, work very closely as a team, and I think the key is networking and utilizing resources. There are like financial advocates at the hospital, Medicaid specialists. Our financial navigator is constantly exploring what kind of grants are available, the foundation. So it's a lot of networking and knowing what's available to be able to assist the patients. But in general, sometimes patients just need to know more about their own insurance. So there's that fear, and we can help relieve that by them just knowing a little bit more about their insurance, and that their insurance actually will cover some of those expenses. So.
Yeah, I think one of the messages that we'd like to leave with everyone is that don't put off care worrying about that. That we will sit down and we'll try to work out as best we can. We have. And this is not just related to cancer, but we have payment plans, but Medicaid access now, since the Accountable Care Organizations have occurred, the ACA, that's much more available, and we just, it's much more from a standpoint of quality, cost, and everything else to get diagnosed quickly than later when it becomes more problematic for all kinds of reasons. Other questions?
Yes. From beginning to end, how long will the patient be involved with the navigator?
Okay, so let's just take, we're talking about breast cancer, and we're going to say that we have someone that's going to take some time because of all the different things. So let's say they've got metastatic cancer or what, however you would like to answer that. But how long are you involved?
That answer looks differently for each patient. Again,
Yeah.
It's very individualized based on their needs. I have patients that I talk to daily that have numerous barriers to care. I may need to do things like schedule their transportation to every appointment. I have other patients that, once they get into treatment, there's so many resources with all of our other staff as far as like infusion nurses, the staff in medical oncology, radiation oncology that are answering their questions and helping them along. So it really is, it's individualized, but we are available to them throughout the entire course of their treatment and into survivorship. Because even patients that complete treatment are still feeling some financial burdens and things once their treatment's completed. So we're available to them.
Well, I would assume there might be a question come up about a medication. I took this medication 2 years ago, and now I read in the paper that it didn't work or that had side effects. So you would be available, that someone could call you that way?
Yes.
And you are part of the individual plan of each of the patients. So most patients are going to have a follow-up in a year that they would have and so you would be available through those kind of things too.
Yes, correct.
Absolutely.
Okay. Jen, any more?
Yes.
Good. Thank you for all your questions out there.
Yes.
Could you tell us about the relationship you form with your patients and how does care navigation reduce their stress?
So let's just talk about the emotional. I think
Okay.
that's sometimes underappreciated, undervaluated, and undervalued for having emotional support. Again, I think anybody that gets the diagnosis of cancer, they start worrying. They've heard all these kinds of stories, even though we think our care is improved and it's not as bad as it was prognosis-wise. So how do you approach the emotional and then answering Jen's question?
Sure. So I think regardless of any cancer diagnosis, the prognosis of that, it's scary, especially to patients that haven't had even a family member go through it. So I think a lot in the beginning parts of meeting patients and the emotional support is a lot of them just able to process the information with us, and somebody that understands the information. When they're trying to talk to their family, it's more of, what can I do for you? Whereas a lot of times we can just listen and sometimes connect them to other valuable resources. We do have, obviously, wonderful community resources with emotional support. We can connect them with counseling, support groups, and then there's also the national level of support as well, which some are online, some can be in person, depends on that patient's preference really. But yeah, a lot of it goes with trying to listen really to what they have to say and trying to get them to the correct resource to help them. And there are some patients that will just want to speak with just their navigator, and that's okay too. If they're not comfortable with reaching out to another entity or provider, we can provide that support as much as possible.
One of the things we talked about before, and I know this from the doctors, is that people sometimes want a second opinion, which is pretty
Yes.
understandable. And I'm sure you would get that kind of question, that somebody might ask about that, and it might be a physician here. Now, as we've tried to talk about, we feel really good care and are able to take care of people. But there are things people are going to move. People may, or the individual may want, as I said, just another opinion, or it's something we can't do. We don't do bone marrow transplants here, or there might be things that would come up that way. How do you deal with those kind of things? Can you be of help to them if they're going to need records, they're going to need lots of things if they're going to go somewhere, and then they're going to be coming back? So that's a logistical. Are you involved in that, or someone is?
Absolutely. If a patient would like a second opinion, we assist in that process with making the referrals in collaboration with their providers. And I think the key is that patient feels comfortable, and whatever they need, we are here to assist.
So let's go on to then talking about the emotional. That was part of the question, and part of mine is how do you interact that way? Or I know we're doing depression screening, and all those things would be expected, but what is your relationship that way, or how can you help, and what kind of, I'm sure you've had some stories about those kind of things.
Yeah, so for each of our patients, we do like what's called a psychosocial distress screening. So we're really looking at any barriers to care that they may have. That can be anywhere from emotional to physical, financial. So we utilize that tool a lot to assist patients. But I think, as Jessica pointed out earlier, listening is the key to navigation, and they really reach out to us for those needs that I feel like they don't feel comfortable talking about in front of family members or maybe in front of their physician.
Yeah, I agree.
Anything you'd add to that, Jessica, about from just let's say emotional support or?
Yeah, I think sometimes there are questions in the patient's minds that they don't feel appropriate to bring to their family, such as seeking treatment versus not seeking treatment. Those are hard conversations that they do have with their physicians, but a lot of times the patient may be feeling one side and maybe not feel like they can discuss that with their family. So those are hard discussions that we may have with a family member or the patient themselves to prepare them for what's down the road if they do not get treatment. And so those are more of the tougher conversations that sometimes patients do not want to bring to their family. And so those are sometimes the harder ones that they want to speak to their navigator about.
Do you get asked about advanced directives? Do people bring those kind of things up, and how do you deal with those?
Sure. So we do have a team within Blanchard Valley, and we connect them with that team to help them understand their advanced directives, and they can actually help the patient complete their advanced directives. We try to connect them with an advocate at the same time that they're going to be within the Arms Cancer Center, so that way they're not making special trips to the center just to go over that information.
Anything in addition to that? You did talk about, we have different kinds of teams.
Yeah.
So how do you interact, or is it more of a referral, let's say with palliative care, with home health, with all of those things that are also support kind of things, in addition to, we've talked about some of the things in the community.
Mm-hmm. Yeah, so we can, make referrals, work with the providers to make appropriate referrals to. We utilize palliative care a lot. We reach out to the Blanchard Valley social workers a lot to bounce different situations and scenarios off of. So there's a lot of networking within the health system, also within the community, because there's a lot of great community resources.
Yeah, the teamwork and networking.
Yes,
those are
absolutely.
both big things. And,
Yeah.
and I think, again, if you've been in that situation or with a family member, you understand how important that is, because questions come up all the time. Jen, we have any other questions?
Yeah, we have a couple more for our time here. You had mentioned about second opinions. Could you talk a little bit about if you work at all with the Mayo Clinic collaboration that the health system does?
So the question is, and if you don't know, all of our viewers, that we have an affiliation from Blanchard Valley Health System with the Mayo Clinic, where individuals with their physician can talk to a Mayo specialist about what the condition is, and then we share that with the patient, and that can occur. So are you two available, or do you work with that, or I know that's mostly related to the physician, but somebody's got to get the data and all that kind of stuff.
Yeah, so there's a process for that comes from their provider. We really aren't involved with that, but we can, assist with that referral if needed. So
yeah, and so maybe I can answer that, because that is a good question. That's a discussion with the physician to talk about if there would be a need, and it has been really beneficial, especially in cancer, because it keeps someone from having to go someplace else. With the modern day, what we have in laboratory pathology and radiology, all these things can be done electronically. You don't have to carry all those things, and it does keep a lot of people home. I think reassures them and expedites timing to get things done so that treatments and things can be started. Good question. Jen?
Sure. One of the final questions here. Can you as care navigators connect patients to clinical trials?
Okay, so the question is about clinical trials. So this is a tumor board question that always comes up, is do we have a process, do we have a trial that someone, if they wanted to be in, do you work with that? Now I know we have a team that runs the tumor board, and that's a highly, I'll say, regulated of what you need to do to be able to do that, but you probably get some questions about that, or you being involved.
So we do have a clinical research registered nurse at the Arms Cancer Center. She continually is looking at new trials and also looks at all of the new patients and the treatments they're going through. She would then let the provider know of anything that would be available to any patients. She also is utilized in other ways as well. She looks at trials even like outside of the system as well. So, do you have anything to add with that?
Yeah, so absolutely. I mean, it's if patients are being screened for
Yeah.
it, and
It's a usual question.
yeah.
It is.
Well, we're about out of time. Jen, do you have any other questions?
None. Through the chat.
So I'm going to summarize a little bit, and then I'll ask you too if you have any last words. Is that this is really complex, and we appreciate that from a standpoint of being providers, that we want to, and I think they both used individual plans. This is something where you really need to spend some time with questions, thinking about it, and you need a relationship. I think this navigation has been one of the really big things that's changed during my medical career, of having someone available. I think that's good for patients, it's good for families, and really good for the community. So I hope we've addressed those kind of things. Anything else you two would like to add that we didn't cover? You're available and you're helpful. Anything, Sarah? Any last thoughts?
Just the relationships that we make with our patients is very rewarding, and I think Jess and I would both say that that's what we enjoy most about the navigation position.
Yes, I agree. I agree. And for our patients to put so much trust in us in the very beginning at our very first meeting, and I appreciate that very much from our patients in the community.
Well, you two probably know, of all of the professions in the United States, nursing is by far the one that's most trusted. You two both typify that. Well, thank you everyone for being on. Remember, we do have a survey. We appreciate that. We'd like to have feedback, things that we can cover, and hopefully this has been useful for you, your time, and that you've learned something.